So I am Allison Zupon. Welcome. I'm glad to have you here with me this evening. It is October, which means it is very, very busy in a breast imager's life. So we're going to talk about a topic that's very near and dear to my heart, breast density, why it matters and what to do about it. This is something that's a hot topic right now, especially with the move towards more personalized breast screening. So the goals of the session, I like to list these out. I want you to be able to describe the categories of breast density on a mammogram. Most of you are going to be already comfortable with that. We'll go through a few new things in BI-RADS 5. Understand that dense breast tissue is the leading common risk factor in developing breast cancer. I want you to understand the limitations of standard mammography in dense breast tissue and be able to discuss the available options for supplemental screening. My disclosure, we are a GE show site, and GE does bring in clients to come see us and see our machines and see how we run things. We kind of have a unique setup here. Since you can't see me, this is actually way better because I'm pretty tired looking today. This is my partner, Dr. Volz. He started in 2014, and I began in 2016 here. So a little bit more about us. As Audra said, we average around 17,000 mammograms per year. The vast majority of these are screening mammograms. Our facility performs all screening mammograms with tomosynthesis. That's now a law in Missouri that insurance has to cover it, and we've been doing that for about 2 years. We also utilize automated breast ultrasound, or ABUS, as an additional tool for patients with dense breast tissue as a supplemental screening. So one thing that makes us unique and will kind of affect what I talk about and recommend, we do all online reading with the same-day diagnostic workup. All of our patients are given the results before they leave, including their breast density. We return our reports back to our referring physicians, usually within an hour, definitely the same day. And then patients with heterogeneously dense or dense breast tissue, we counsel them that day and offer same-day screening breast ultrasound. So all of that happens when a patient presents for a screening mammogram. Could be her first time, she could be here many times. We do all these things, same-day workup, and discuss her breast density at that time and give her tools for what to do about it. We can all agree, I believe, these mammograms save lives. We have 40 years of data to back up. But we can and we should do better for our dense-breasted patients. There is a gap in detection for our heterogeneously dense and dense-breasted patients, and we need to recognize that and give women options. So we'll just start with the first part of my lecture. What is dense breast tissue? As I said, we all know what dense breast tissue looks like, and there are several categories. So 4 categories. A, my absolute favorite category to read. I wish I could have an entire clinic devoted to this. Almost entirely fatty. You can see a 3-millimeter cancer from the door in a fatty breast. Scattered fibroglandular densities and heterogeneously dense, those make up the majority of what I see, unfortunately, in a day. So scattered, we're getting some glandular tissue, but you can still fairly see through it pretty well. The heterogeneously dense and extremely dense are where the breast tissue is starting to become more and more a part of the overall breast parenchyma and start to mask findings. And, when you get to the extremely dense category, your heart just sinks. It's a pretty rough mammogram to read. So I wanted to include the ACR BI-RADS density reporting categories. So we break it down, dense tissue by percentage of the breast. That means you look at the breast tissue, either in person or with software, you take the percentage of glandular tissue as a part of the total breast. So if the glandular tissue is less than 25%, we're looking at category A, the breasts are almost entirely fatty. 25 to 50 is that B, or scattered, and then 50 to 75 is category C. The breasts are heterogeneously dense, which lowers the sensitivity of mammography. That's an important statement. This is in the BI-RADS classification. Right there, it says it lowers the sensitivity of mammography. And then your category D are the near whiteouts, with the breast tissue being extremely dense. There are some optional descriptors of breast density. Can be up to you whether you choose to use them or not. I personally don't. Mentally, you can make a note of what these are if you want to, but again, I just usually don't report these. Ours are set up for ABCD. A few scattered areas of fibroglandular density versus moderate scattered. This is one of the borderline cases where there are areas of masking, and when you look at a breast, you assess for the overall parenchymal density, but you're also looking for, are there areas of extremely dense tissue where you still can't see? So category C also has an optional descriptor. That was two optional descriptors. This one is the dense tissue is located anteriorly in both breasts. Posterior portions are mostly fatty. This is still a dense breast. Even though this dense tissue is predominantly in the subareolar breast or anterior breast, you've got a nice area of fat behind it. This is still a dense breast. You can't see through that tissue. So that is classified as dense. And with category C, it's very similar. It's just different location, upper outer quadrant. These are pretty common patterns, the anterior breast, the upper outer quadrant. So again, despite the fact that there's a lot of fat in this breast tissue, up here you can't see. This is a dense band of tissue, and that's going to influence what you call that, whether you call it a B or a C. I would call that a C. How do we measure breast density? This is predominantly by radiologist assessment, meaning it's an individual decision that you make at your reading station, and you're visually looking how much fat is there versus how much glandular tissue. I kind of have a gut reaction, I would say, too. Do I look at it and my heart sinks because I don't really want to read it? It's so dense. So it is subjective. There's definitely going to be variability with this method, not just between you and your partners, but probably you from last year and you from this year. Last year, you might have had enough coffee that you feel like a superhero and you can read anything. And this year, you're pretty sure it's dense and there's no way you could find anything in it. When you're looking at it by yourself, you can assess for areas of potential masking and decide how well do you think you can see through it. What I think is interesting is that we don't know what matters more. Is it this overall volume, or is it these very, very dense bands of glandular tissue, or that dreaded category where you're not sure if they're heterogeneously dense, but the pattern of the breast parenchyma is very complex with a nodular pattern that looks like there are masses and maybe even distortion all over the breast tissue. So we're not sure what actually matters more as far as breast cancer risk. Right now, they're put into the same kind of category of that heterogeneously dense. The alternative to doing a personal visual assessment would be to have software. That decreases variability. It is an extra expense, and if you're very comfortable assessing breast tissue, it's just personally we have looked at software, but with the expense, we continue to assess it visually because it just doesn't make financial sense for us to add the software. We're very comfortable. We read so many mammograms a year. You're not required to use it, and you should know that with different breast positioning and depending on what software algorithm you choose, the breast density can vary. We all know breast density can vary with positioning, with compression, with phases of the menstrual cycle as well. I want to talk about what might influence breast density. Women ask me once I talk about breast, I tell them that they have dense breasts. A lot of them ask, well, what can I do about that, or what causes that? We have some research that kind of shows that diet is a factor in breast density. I certainly know women who have also lost 100 pounds who have presented with new dense breast tissue just because the fat is predominantly gone from their breast. High alcohol intake is associated with increased breast density. The environment, proximity to urban areas specifically, can lead to increased breast density. Hormone replacement therapy is a big one. I have a lot of patients who are on HRT, and there's a noticeable difference right when they go on HRT. You can tell from one mammogram to the other that they've increased density, and then we have to have that conversation. There's a study out about chronic low-level inflammation also leading to breast density, which I find very fascinating. That's not something I'm talking to my patients about yet, about aspirin. I don't have enough information on that yet. Then, after they ask, why do I have it, they ask, what can I do about it? Most of the time, nothing. A small percentage of women just will never have that breast density decrease over time. The majority of women will have it decrease as they go through menopause and as time goes on. If we can reduce their breast density, though, we can reduce the women's breast cancer risk. So there's currently a clinical trial regarding use of tamoxifen gel. That's in the pipeline. Otherwise, there's stopping HRT, decreasing alcohol. Those are other possible ways that a woman can decrease her breast density. So now that we have established what breast density is, next we get to talk about why does it matter. The most important thing that I want to convey in this lecture is that breast density is an independent risk factor for breast cancer. It is not just that it's harder to see in dense breasts, which it is, but it's an independent risk factor. When I do talk to patients about it, I describe it as, I tell them I'm trying to find a snowball in a snowstorm in these breasts because I'm looking for a white cancer surrounded by white tissue. And sometimes that white next to the white, you just can't see it. So that's how I explain it to my patients and to the referring physicians when I'm talking about that. Another reason why it matters is just the sheer volume of women who have it. Many of our patients have it. At Imaging for Women, we predominantly cater to the working woman. That's our practice makeup. So we have, most of our patients are in their 40s and 50s, and these are the women who have, the majority of them have BI-RADS C or D density. So it's a big percentage of our population, but even women in their 60s, 30 to 40%. So, and about a third of women, even in their 60s, they have that increased risk and increased risk of masking it too. I actually have this graphic in my office, and I will show patients to explain to them what I mean when I'm telling them that what I am up against. I think it's helpful. We have pictures in like a TV display in the waiting room with this, just to say, hey, what would you like to look at? Anybody can look at this and understand that what you are facing with a dense breast. Again, I'll probably say this multiple times. Breast density is the leading common risk factor for development of breast cancer. So the leading common risk factor, what does that mean? That means it is greater than your family history, personal history of benign lesions, first full pregnancy after age 30, early menarche, late menopause. What I just listed, these are the big five that I think most of us think about when we think about the risk factors in a general population. So I'm not talking about the genetic mutation or those patients or the mantle radiation at a young age patients. I'm talking about the common risk factors. I think one of the first things that women tell me, if I tell them that they have a suspicious lesion, they'll say, well, I don't have a family history. Well, that's not even as big of an issue as this breast density, and it isn't in their minds. The fact that their breast density makes them at higher risk. So that's the leading common risk factor. Not only does it put them at higher risk, but again, it makes it harder to find. So more than 70% of breast cancers are happening in these women with dense breasts. However, mammography, the sensitivity of it drops off precipitously as women's breast density increases. And that's to the point where nearly 1 in 2 cancers is missed on standard mammography in extremely dense breasts. Now, we'll talk about tomosynthesis and how that increases the cancer detection rate. We'll talk about that in a later slide. So, unfortunately, women with dense breasts are more likely to have their cancer found as a lump or a symptom in between screening. So that's an interval cancer. Interval cancers have a worse prognosis. So women with dense breasts are more likely to get that breast cancer, and they're more likely to have it found as a palpable mass. So kind of to the next part of my lecture is that we have all this information as physicians, and as radiologists, we are often knowledge holders, and we are the physician's physician. But patients should know and understand the limitations and risk with their dense breast tissue. We are entering, or already in, really, an era of personalized medicine. And it is important that we share the knowledge that we have with the patients, because the woman, is actually the person who needs to make a decision on what kind of supplemental screening she needs to pursue in order to increase our ability to find that cancer early. So we can't just keep it to ourselves. We have to let patients know. Luckily, breast density awareness is growing. So this has been a national movement. Started out as a small movement by a woman who her breast cancer was discovered after she'd had a normal mammogram, and she didn't know what did that mean that she'd had dense breast tissue and had a normal mammogram. So since 2012, where there were only 4 states with enacted laws, in 2019 we now have 38 states that require notification. I'm in Missouri, so we've had that notification law for as long as I've been practicing. It's just been a part of our practice. There's now, this is a pretty recent development, so now the law in the United States is that the the Federal Drug Administration needs to develop breast density reporting language that is included in patient letters and healthcare provider reports. So this is now going to be a national movement, that it's no longer just a state-by-state requirement. We don't have the exact language, but it will set a minimum. So even if you're not in a state where it's currently required to notify your patients, it will be. You will have to notify your patients, and you need to be ready for how to answer their questions about what that means. Because I think when the notification laws first came out, it was one of those great intention things where we are required to tell people, but then they ask, well, what does that mean? Or, well, what can I do now? And if you don't have any solutions to offer them, you just kind of scared people without giving them any answers. It's going to be important to be educated and be able to discuss this, because there's already confusion with just mammography screening guidelines. And as I said before, we have more than 40 years of data saying that mammograms save lives, and we still have the USPSTF coming out saying, 2-year interval of screening cancer. There's been no documented case of breast cancer spontaneously regressing, but we still have confusion about that 2-year window. The major players in cancer care is annual screening. Our recommendations with the ACR and Society of Breast Imaging are annual, starting at 40, until life expectancy is less than 5 to 7 years. We have that conversation with patients. I also put the JACR guidelines for I have average, intermediate, and high risk, because those differ depending on the personal risk of the woman. Your facility may calculate risk. There's a variety of calculators that you can calculate your risk, but for whatever you use to determine the patient's risk, if they are average risk, mammography and digital breast tomosynthesis screening, usually appropriate. That's our gold standard. And then ultrasound of the breast may be appropriate. So at our facility, we offer that to the dense and heterogeneously dense breasted patients, even with average risk. MRI, at this point, not appropriate. Usually not appropriate. Same with the molecular breast imaging. These are the current JACR guidelines on that. So once you move up to intermediate risk, MRI is it's now in the maybe appropriate category, along with ultrasound. In my personal experience, insurance companies will not pay for MRI unless the patient is at high risk, which is greater than 20% lifetime risk. So that's not something that I counsel my intermediate risk patients as an option, because even if insurance covers it, the financial burden can just be too much for a lot of patients. And so if insurance doesn't cover it, I have maybe had one person in 3 years say, well, she didn't care if she paid out of pocket for an MRI. Once we move up to the high risk category, now we're into where MRI of the breast with and without IV contrast is usually appropriate. And actually ultrasound of the breast moves down to maybe appropriate. These are the practice parameters that we follow in my practice. If a patient has a lifetime breast cancer risk of greater than 20%, I recommend that she have an MRI, which we don't actually have at our facility. So I'll recommend that she go somewhere else. I want that patient to get the best imaging possible, the most appropriate imaging for her particular risk. So and she's getting an MRI annually, I tell her not to worry about the ultrasound. So we're back to work in a busy October, and patients are beating down the doors, wearing pink ribbons, and everybody knows that it's Breast Cancer Awareness Month, so they want to get things done. Your patient presents for screening mammography, and she has dense breast tissue. Now what? That's the key issue. You can tell them all, but now what are we going to do? So our current screening options, there are several, many of which are not actually FDA approved. So digital mammography, preferably with 3D or tomosynthesis. 3D is a proprietary, so it's not really a 3D image, it's tomosynthesis. Supplemental screening with ultrasound, contrast enhanced mammography, not FDA approved. And we'll go through several of these. Molecular breast imaging, which is also not FDA approved. Some sites are using it as a screening tool, same with contrast enhanced. And then supplemental screening with MR. It might surprise you, this is a very common practice, even something I recommend. It's not actually FDA approved for the screening population. So this is also reserved, as I was saying before, for women with a high risk of breast malignancy. So regardless of tissue density, they can have a scattered breast, and they're above 20%, I'll still recommend an MRI. There was just an article in USA Today about tomosynthesis. Is tomosynthesis the answer? I'll refer to it as tomosynthesis, but just in the lay population, it's sometimes called 3D. Regardless, it's tomosynthesis. So this is quickly, in my opinion, becoming the standard of care. As I said, at my facility, we have been doing only tomosynthesis with the reconstructed V-preview images for about 2 years. It can help in detecting distortion, and the incremental cancer rate detection rate is about 1 to 2 cancers per 1,000. A big benefit of tomosynthesis is that it's been shown to reduce false positive callbacks. And anxiety is often touted as one of the issues with screening mammography. It makes women nervous when they get called back, when they have additional imaging, so tomosynthesis can decrease that false positive rate. One problem with tomosynthesis is that right now the data doesn't show that we are significantly increasing our cancer detection rate in those extremely dense breasts. Even with tomosynthesis, if you have a white cancer immediately adjacent to white dense tissue, we're taking very thin slices, but we're still looking for density. So that can mask it, even in extremely dense breasts. So I definitely would say it is not the answer for extremely dense breast tissue. So the women with the heterogeneously dense and extremely dense breast tissue, they still have a gap. The mammography does not work as well for these women as it does in the women with scattered breast tissue, and especially fatty breast tissue. When we're looking at, let's look at digital breast tomosynthesis head-to-head with screening breast ultrasound. Actually, ultrasound definitely comes out on top in dense breast tissue. 13 invasive cancers that were seen by ultrasound only compared to 1 that was seen by tomosynthesis only. At Imaging for Women, this is how we see tomosynthesis and ultrasound. These are complementary. Before we started doing all 3D, all tomosynthesis, we did have patients ask, well, I'll do the 2D mammogram and then have an ultrasound. And there's a cost differential there. So if they didn't want to pay for the 3D imaging, I let it go. I would rather have the ultrasound because that had been shown to find more cancers than just adding tomosynthesis. But now I much prefer having both of them. I do think that they complement each other. As you can see, ultrasound, which I'll talk more about later too, it has an incremental cancer detection rate of 3 per 1,000 versus 1 to 2 per 1,000. I'll go briefly over contrast enhanced mammography because it is not FDA approved for screening. It's not really currently in use for screening. So this relies on the ability of the metabolism of cancer, essentially, to take up the contrast agent. So you have to start an IV, inject contrast, and then you have a 2-minute wait time before imaging. 2 exposures are taken in each view. One's a low energy image, That mimics a standard mammogram, and then you have a high-energy image. Your software performs a subtraction and creates an iodine-only image. So what happens is you have the areas that are lighting up with contrast and on the subtraction image, and those are the areas of increased metabolism. So you can have a pretty accurate view of where in the breast has increased metabolism. So, as I said, not currently FDA approved, but studies are underway. This could be something that becomes a standard of care. What's pretty exciting about contrast-enhanced mammography is that it's equal or nearly equal to MRI in ability to detect breast cancer in multiple studies. So it's an excellent alternative for patients who either can't afford MRI or can't physically do an MRI. This is a great tool. It does have a shorter scan time, much less expensive. For a private facility, or really for any facility, it does require an IV placement. At my office, we don't have a nurse, so you have to have a nurse or a phlebotomist to come in and place that IV. And then with the iodinated contrast, you have the risk of a contrast allergy, and then you have to assess patients for renal function. There is a little bit of an increase in radiation to the breast with this method. Right now, there's no direct method to biopsy abnormalities, but typically this is something that would then, if you see an abnormality, you do a second look ultrasound, much like with MRI. If you do a screening MRI, you're going to do a second look ultrasound and see if there's a target to biopsy under that before you go to other methods. For molecular breast imaging or breast-specific gamma imaging, another one that's not currently approved for FDA approved for screening, excuse me. But it might be an alternative screening for women who are unable to go MRI. This is a pretty high cancer detection rate, incremental CDR of 7 to 8 cancers per 1,000 women. This is a specialized nuclear medicine study. Might not be possible for places like mine that don't have a hot lab. It requires IV injection of the radioactive agent. And it is another imaging, a functional imaging study that requires that depends on the metabolism of cancer. This does give a radiation dose to the entire body. Unlike any other screening tools that we have, this gives a radiation dose to the whole body. I'm going to move on to ultrasound next. I'm really not going to talk about MRI on this at this lecture because it's reserved for that high-risk population. It's not a screening tool, or at this point, not a potential screening tool for the entire population, which might change in the future. There are fast MRI protocols and maybe even a no contrast protocol. But at this point, for the purposes of this lecture, I'll stick to what's currently being utilized for screening in the general population. So ultrasound screening. Ultrasound screening can be applied to women with dense breast tissue at normal, intermediate, and high risk. MRI and the molecular imaging and contrast enhanced, those are typically more for women with higher risk, but ultrasound screening depends on the density of the breast tissue. That's how we make our recommendation. The CDR, it's a pretty wide range. Some of the initial studies that got to 7, those were comparing to standard mammography, and 2 to 6 per 1,000 is about the range. At our facility, we find about 3 per 1,000. ABUS is the automated breast ultrasound. That's the only FDA-approved device for breast screening as an adjunct to mammography. But handheld ultrasound is being performed. If you don't have a device, some people are, they see a woman with dense breast tissue, you're already going to look at a mass, and they'll screen the other breast with handheld. I'll go into automated breast ultrasound more. This is what we use at our facility, and we've used it since 2014. So here's the machine. A technologist places this scanning unit on the breast like so, and the entire breast is scanned. So the images are acquired and then reformatted into coronal and transverse planes. The radiologist has a workstation this is the workstation, and you scroll through the images. First you scroll from skin toward the chest wall on the coronal, and then you look at the transverse images. You're looking really, it's like you were doing the ultrasound, and you're looking for any kind of dark, ugly mass, anything that looks like it's not just normal breast tissue or a cyst. This is why we put ABUS in our facility. Bilateral screening breast ultrasound has been repeatedly shown to increase CDR in our women with dense breast tissue. Some particular things that I like about this modality versus handheld ultrasound, automated breast ultrasound is it reduces operator dependence. So, depending on what technologist you have, you might trust one more than the other. It's just kind of how it is. But with this, you have a standard set of images that you acquire during that exam, but also year after year. So it reduces your dependence on having a sonographer show you the images that they find are suspicious. You get to look through the entire breast tissue. You have year-to-year comparison. I feel like the year-to-year comparison really helps reducing my time, because I can find something on an image this year and I can quickly look at it last year and see if the area looked the same. And we've worked it into our facility very efficiently. Here's the just kind of the comparison of many of the studies, including Akron 666, which is the really big trial showing cancer detection rate. Again, here's the range from 2.6 to 7.1. So multiple studies demonstrating the effectiveness of screening ultrasound at finding incremental detection cancer, and finding cancers in women with that dense breast tissue. I'm going to talk a little bit more specifically about how we are addressing this problem of dense breast tissue in our facility. So at Imaging for Women, we started performing ABUS in 2014, and we really launched a program to educate our referring physicians and our patients about breast density. We educate each patient, and we also held lunch and learn sessions to educate physicians about breast density, and sent out newsletters. We really put out an information campaign to try to get people to understand what this means. For us, it's our chosen method for closing that detection gap. And at my facility, we have patients who, for concerns about radiation, sometimes concerns that compression will spread cancer through their breast, for whatever reasons, they are not comfortable receiving mammography. My personal opinion is that if I can offer them something for screening that is effective, then I need to offer that. So we also use ABUS as a radiation-free screening tool. I do counsel each patient who chooses that about the benefits of mammography, and mammography can find cancers in calcifications or distortion, and we use them together. I give them that information, and then if they still decline, we use ABUS for a screening tool. So when a patient comes in for a screening mammogram, if I read it as normal, either myself or my assistant will go talk to the patient, give them the results, and counsel them on breast density. We have a script that they are very well practiced at by now about you. Dr. Zupon says you have heterogeneously dense breast tissue. This is an independent risk factor for breast cancer that increases your risk and also makes breast cancer hard to see. It's something along those lines, and it talks to them about why the mammogram is not as sensitive, and then we offer them supplemental ABUS screening at that time. So they can come in for a mammogram, and if they want an ABUS, we will do it right then. It takes about 15 to 20 minutes per patient to complete the scan, and then my read time is about 3 minutes at this point. There is a learning curve, but my read time is down to 3 minutes now. It requires an order from a physician because it is an ultrasound. So even though it's a screening exam, it is an ultrasound. It requires an order from the physician. So we have worked out with our physicians where the vast majority of them, we have standing orders. So conditional or contingent orders that include ABUS if the mammogram has dense breast. We'll call if we need to, call their referring physician's offices, but after that information campaign, we mostly can just do it and add it on. And here's why it works for us. We can't get it would be cost prohibitive for us to put an MRI in. It's also the problem of acquiring a certificate of need. We're in a pretty densely populated area for MRI, and I don't think we could even get the certificate. It doesn't require a nurse or phlebotomist, and it's inexpensive. We always have a cash price at Imaging for Women, and that's a big deal for our patients. They don't want to add on another exam that's $500 or $800. They can't. They just can't add that on. So We offer this cash price, and we can bill it to insurance. It's covered by insurance, but we give them the option. We talk to them up front. We just give them the information and let them choose. I don't have to worry about a contrast allergy. I don't have to worry about renal insufficiency. I don't have to worry about additional radiation. It is the only FDA-approved screening method, so that's why we're comfortable with this right now. Here's the algorithm that we use to assess who gets to supplemental screening. So if they're average and dense, we offer ABUS. Intermediate dense, offer ABUS. If they're high risk, again, like I said earlier, even dense or not dense, I recommend an MRI. I always like to close with a case to keep you up at night. My partner is just a master at saying, hey, I want you to look at this. Tell me what you think about this. And it's some awful case of ILC that you just can't see it all and makes you regret ever going into breast imaging. So this is one of our patients who presented with dense breast tissue, normal mammogram. She did have a family history of breast cancer, so we offer her an ABUS. And it was an asymptomatic screening ABUS. So I'll show you her mammogram just so you can look at it. I'll give you a minute or two and tell me how right I am that it's normal and that there's nothing that you would ever call it. We did have tomosynthesis. At that time, we were doing 3D MLOs and a standard full field digital CC image. Okay, that should be enough time. There's nothing there, promise. Every hotshot who's looking, there's nothing there. So here's the automated breast ultrasound. And as you can see by the arrow sign, this is what's called a black hole on the coronal image. That's the coronal image. And we have this black circle, but you can see it looks like there might be some distortion, maybe some speculation. And this is the transverse image, demonstrating a pretty ugly looking little mass. This is not a cyst. You can tell that right on this image. This is not a cyst, despite its nearly anechoic echo texture. Software will tell you where it is in the breast, the o'clock and the distance from the nipple. So you can send a sonographer to look at that with handheld imaging. I'll give you a close-up. This is a close-up of the like a more image of the transverse imaging. Excuse me. So then we always do a handheld ultrasound for any suspicious findings. That lets us look for blood flow, and it lets us assess the axilla. Oh, I got a question. I'll answer that in just a second. So this handheld ultrasound, I use all the bad words: hypoechoic, spiculated, taller than wide, shadowing, posterior acoustic shadowing, all the bad words for this one. And then I did a biopsy. So after the biopsy, or maybe I didn't, maybe my partner did, because I think it's a little hematoma. So after the biopsy, it must be my partner. That's where the tissue marker was. And I'll show you the pre and the post together. This was an ILC, a grade 2 ILC. These are the ones that keep us up at night. They're the mammographically occult, single file cell growth that doesn't make a mass. Luckily, her lymph nodes look normal. So I'll show you the post-biopsy mammogram versus the pre. And this, we're looking right here. There's just nothing there. There's just nothing that you could call. So you don't feel bad that you read this as normal. There weren't any findings. It is a normal mammogram or a negative mammogram, but it's just not the whole story. So to conclude, I think I'm right on time. Breast density is the leading common risk factor for developing breast cancer, more than all the other ones that we usually think about. Dense breast tissue can also mask cancer on a mammogram, especially in extremely dense breast tissue. When we're telling women that they have a normal or a negative mammogram and they have that extremely dense breast tissue, we are not giving them the whole story. We need to tell them that, this looks normal, but 50% of the time I wouldn't see anything anyway. There are several options to improve our outcomes, and we're learning more all the time. So I really want to stress, we are the knowledge holders. We have a responsibility to educate our patients. Radiologists, especially in breast imaging, we just can't stay in the dark room. We have to be the educators, and we have to let people know, why is this important? What can we do about it? How can we make screening for breast cancer the most effective for all patients? All right. Thank you very much. I already have a question. Can the patient receive an ABUS the same day, or does the patient have to wait a certain period of time in order for insurance to reimburse? No, they can have it the same day. That's typically how we add most of ours on. Either if they're a new patient, or they just decide that today's the day they're going to have an ABUS, then we'll add it on. But for our patients who are returning, our schedulers actually ask them if they would like to schedule the mammogram and ABUS. So one caveat is, if I read the ABUS and then I find a mass and I want to do an additional targeted handheld ultrasound, we don't charge for that. That's a decision that we made as a practice, because that you can't charge for the same day. So we don't. And to me, you just pop the patient in a room and you do a quick ultrasound scan of that targeted area. I'm completely fine with not charging for it, and it reduces your callback. It reduces the patient burden, because she doesn't have to come back in on another day. And especially as you're learning to read ABUS, it's very nice to be able to just have immediate confirmation. Yes, that was something. No, that wasn't anything. And that's part of our approach toward patients, is to do everything in one day, so that they don't have to have that agony of waiting for the next exam and going home thinking, oh, I have something abnormal and I have to wait until I can schedule a diagnostic. So we do it all the same day. ABUS doesn't have capability for biopsy. Sorry, I have another question. Do you perform the biopsy under the ABUS or the regular sonogram? We perform biopsies with the standard ultrasound, the handheld ultrasound. Once in a while, if the patient can't stay for the handheld ultrasound after the ABUS, I'll just recommend the ultrasound guided biopsy off of the ABUS. And then we do the pre-scanning when she comes in, and look at the axilla when she comes in for her biopsy. I'll just share this while I'm waiting for some additional questions. We currently do 27 ABUS exams per day. After our education campaign, so this has changed. When I first was here, we had a 20% rate for dense breasted women to have an ABUS. So that was in 2016. And in the intervening years, where we've really made a push to educate patients, and just every single time they're there, talking to them about it and giving them information, giving them a brochure on ABUS, now we have about a 50% utilization rate. So for those women, it's pretty humbling when you see a cancer on the ultrasound that you just flat out would never have seen on the mammogram. I felt the first time I saw it, I thought, my gosh, I sent that woman home with cancer. I was just out of fellowship, and I thought, I told her it was normal, and it wasn't. These are just the size of the cancers that we found. We published a white paper about our findings and how many we found. I have another question. How often do you end up following lesions or biopsying them that are found incidentally on ABUS but don't have typical cancer imaging characteristics? Part of reading an ABUS is knowing that you are reading a screening exam. So Dr. Stavros talks about this. You are not reading a diagnostic ultrasound. You're not reading an ultrasound for something that, unless you can do diagnostic ABUS, which is a totally different topic, but you are reading a screening examination. So if you see fibrocystic change throughout the breast tissue, and then one of the oval parallel circumscribed masses is hypoechoic and not anechoic, you're reading a screening exam. That the odds that are cancer are low enough that that's not what you're looking for. So we do end up following some solitary fibroadenomas, or occasionally, I think what will happen more often is you'll have an inflamed dirty cyst that you're not sure if that is a mass. It looks like one, but then it collapses under biopsy or aspiration. I have any cases where you can't find the lesion detected on ABUS, but not. I think they're asking, have you had any cases where you can find a lesion detected on ABUS, but you can't find it on handheld? Yes would be the answer if I'm reading that correctly, because ABUS is great at finding distortion on that coronal image, and sometimes on real time you just can't appreciate that distortion with handheld imaging. So it has helped me confirm that's more of when I use it in a diagnostic setting, when I'm looking for that distortion. Maybe I see distortion on the mammogram. Now, if I see an area on the A-bus and I'm not sure if it's real, I'm not sure if it's shadowing, and I go in with handheld ultrasound and I don't find anything there, yes, that happens. And then I let the patient go. So that in a screening exam, if it's a real lesion, I haven't had that problem, but you do occasionally get a little faked out by maybe it's a cyst that looked dirty, but then you get in there and you do a handheld ultrasound. You can apply pressure in a different angle or direction, or just have the patient rotate a little bit more. So then you can clear up things that might have caught your eye on A-bus, or it just didn't exist in the first place. Tell us about educating your referring physicians. So as I mentioned, we had a lot of lunch and learns. We had a monthly newsletter where we repeatedly talked about breast density. We physically went in and brought the referring physician's office's lunch and had brochures about it and talked to them in person. We called on patients who accepted. We would call the doctor's offices, and if patients said, "Oh, I need to talk to my doctor before I get an A-bus," I'd actually call that physician's office and say, "Here's why I recommend this." So it was a very personal approach to reach our referring physicians and educate them, and it. At the time, it took several years, but now I just think there's so much more education out there that people, it's just exploded. Our practice with A-bus has really increased. We went from having one A-bus machine in 2016 to we have one A-bus machine in 2017, and then we've since added two more. So now we're at three in just 2 years, and with great utilization of these A-bus machines. So, with referring physicians, family practice physicians, and OBGYNs, patients look to them for advice on what to do. They have a trusting relationship with those physicians. So that's part of why we targeted them for the education, because the patient would go back and talk to their doctor, their OBGYN who delivered their babies. They want to hear from that doctor that this is okay, and that yes, this is something that is recommended. I also gave a lecture last year in 2018 to ACOG about breast density. Another question, do you dictate the mammo and A-bus as one report, or do you dictate them separately? I do one report. Mammogram, A-bus, additional handheld imaging if necessary. It's all one report that goes out the same day. Oh, my practice administrator is with me. She says that they are separate reports, but they're on one page. They are under different headings. So it's one physical page that goes to the physician. But I dictate the mammographic findings, and then I dictate the ultrasound findings. Do you perform A-bus on women with a personal history of breast cancer? Yes, I do. Our techs, so you can train sonographers, but one of the great things about A-bus is that you can also train mammographers, which is a more efficient use of your time, honestly. The sonographers are just a higher paid technologist, so you can train mammographers, and mammographers, I think they do great. They're used to positioning. They're used to moving a patient around and getting her into position and putting down a paddle, so they do great for us. And so the reason I'm saying that is because, yes, even women with lumpectomies, we still can do A-bus on those women. If I see a woman with a history of breast cancer or a family history, we will have even a special script to go talk to them. I put that into when we're talking to patients. They each have their own dressing room, so we go talk to them and we'll say, "You have heterogeneously dense breast tissue. I also noticed that your mother had breast cancer. So with the family history, your calculated risk for breast cancer is 18%. That's considered intermediate risk for breast cancer. And I really recommend that you get a screening ultrasound." So, yep, and we do A-bus on implant patients too. I really like A-bus for those women who have the dense breast with masses everywhere. You know that they have cysts, but I don't want a sonographer to spend 45 minutes or an hour scanning and showing me every one of those cysts. I tell them not to, but it still happens, and they still have to assess every one of those cysts. So using A-bus for those patients is especially efficient. And then if on the mammogram next year, they're positioned a little bit differently, you see a new mass, you can go back to the last year's A-bus and see if she had a cyst there. Just really quickly, screening, I want to reiterate, screening ultrasound is covered. But in our experience in imaging for women, it's covered. but it might be applied towards their deductible. That's the reason why we keep our costs low. But that's going to be any kind of screening. So in order to have a population-based screening program, you got to consider the cost of it to the patients.